Thank you so much. Good morning, good afternoon, and for some of you, good evening. My name is Brian Morales. I am the Chief of the Counter-Narcotics Branch in the U.S. Department of State, Bureau of International Narcotics and Law Enforcement Affairs, or INL for short. Welcome to the first meeting of the Sub-Working Group for the Global Coalition to Address Synthetic Drugs. This is Sub-Working Group 3.2, Engaging People with Substance Use and Substance Use Disorders. I have a few administrative announcements before we begin. This is the second session of 3 public health sessions taking place today, October 26th. We had also yesterday 4 sessions, 2 on manufacturing and trafficking and 2 on detecting drug threats and patterns. And last week we had all of these 7 sessions for the Western group. This is the Eastern group session. At the bottom right hand of the screen, you see the email address syntheticscoalition@state.gov. That is the email address where you can reach us with any concerns, questions, issues. We want to make sure that you have a productive experience over the coming year in working on the coalition deliverables and initiatives. So we welcome you to reach out to that coalition email address for any support that you may need. I want to also share that registration for the working groups and the sub-working groups remains open throughout the year of the coalition. It is open to government and to international organization staff. If you would like the hyperlinks, we are happy to send them to you if you email us. And we invite you to send these to other ministries, other colleagues that may be interested in joining. We have a new website that is under development for the coalition. All of the recordings from today's presentations will be posted on the website, but importantly, we will not be recording the comments from the participants in the meeting. So that will allow for maximum opportunity and comfort of the participants to speak. Also, we are grateful for international organizations that have identified coordinators who will be preparing a summary of the meetings, and we will be posting all notes, all meeting summaries, all the minutes of these meetings on the coalition website for you as well. In the next few weeks, the Secretariat will be sending the meeting schedule as well as calendar invites to all of the participants for the next few months. And if you are interested in a greater role in the coalition, we are looking for co-chairs for sub-working groups 1.1 on manufacturing and 2.1 on data collection and analysis and trends, including early warning. If you're interested, again, please email the coalition email address. Now I'm going to conclude by sharing the meeting schedule for the coming year. We are going to begin today's session by framing the issue, looking at the major challenges related to our topic today. Then, between the months of November to February, very importantly, we're going to be looking at specific interventions, initiatives, and activities, moving beyond discussion and into action. We want to make sure that we have concrete operational work that we do together as part of this coalition. So we'll be identifying different points of intervention, and we will be making commitments in terms of where we would like to continue working or expand our work or initiate new work that we haven't done before. Then we will have a meeting with the co-chairs of the working groups, where the sub-working group co-chairs will report to them the progress that's been made in the coalition month throughout those months. Then between April to July, we will be focused on action planning and implementation of the deliverables and commitments that we have been looking at. And during the month of August, we'll be looking at evaluating and how we evaluate progress, and then how do we transition these initiatives to other places so that they may become sustainable. Because in September, the coalition will come to an end. We will have our final coalition working group meeting in September. And what we'll do then is have a final report, and the sub-working groups, again, will report to the working groups what progress has been made throughout the year, and then how we will continue these efforts over the years to come in a more intensified and sort of interconnected way than we have worked previously. So I will stop sharing my screen. Those are my announcements for today. And I will now take the opportunity to welcome our esteemed colleagues that are helping lead us today. I'm going to begin with the International Organization co-chairs. International Organization coordinators. We have George Murimi, Program Manager from the Colombo Plan, and Anya Boos, Program Manager from UNODC. It's actually quite early in Vienna, so I'm not sure that Anya is here joining us, but I'll turn it over to George for his greeting. Thank you.
Thank you very much, Brian, and greetings to every one of you from the different parts of the world. I also want to pass on our appreciations for your participation. It's a great honor to be able to work with you. I work for the Colombo Plan Drug Advisory Program, particularly charged with rolling out the Universal Prevention Curriculum, the Universal Treatment Curriculum, and the Universal Recovery Curriculum. And I'm glad to say that in Africa, we've been able to get to over 20 countries with quite a number of you here who have been very, very instrumental in helping us to grow. So I look forward to this, and I thank you.
Thank you so much, George. Now I'd like to introduce our two co-chairs for the sub-working group, for this sub-working group. From Indonesia, we have Dr. Riza Sarasvita, the Deputy Director of Rehabilitation from BNN, the Drug Commission there. And then from India, we have Dr. Yatan Pal Singh Balara, Professor of Psychiatry from the All India Institute of Medical Sciences, or AIMS. I'll turn it over to them to introduce themselves as well.
Hello, everybody. My name is Riza. I'm a Deputy of Rehabilitation of the Indonesian National Narcotic Board. I'm now in Bali at the moment because on duty. So, but the vibe is very holiday.
Okay. Hello, everyone. My name is Yatan Balhara. I'm a professor of psychiatry at National Drug Dependence Treatment Center in India. We are the nodal center on substance use disorders for the ministry. I'm also a global trainer on drug demand reduction for Colombo Plan and UNODC, and I'm really glad to be here. Really glad to be part of this group. Now, moving ahead with the agenda for today's session, we have a presentation.
Excuse me, Dr. Tan, I would be remiss if I didn't also invite, we have here with us the co-chair of the working group for public health. So I would just like to, before you take over, just invite Secretary Catalino Cui, if you could also, this is a new sub-working group, if you could give us your opening remarks also, and welcome. Thank you so much, sir.
Thank you, Brian, and welcome to our panelists and participants. We hope that you'll be able to share your valuable insights and comments and maybe best practices in your respective countries. So we should be able to come up with a very strong and effective measures in order to solve the existing problem. Thank you.
Thank you. Thank you so much. Apologies, Dr. Yatan. Please continue.
Sure. Okay. So it gives me immense pleasure to introduce our speaker for the session. She is Ms. Giovanna Campello. She is the Chief Prevention, Treatment and Rehabilitation Section for UNODC. Today, she'll be talking about global landscape and challenges. So I invite Ms. Campello, please.
Good morning, good afternoon, distinguished co-chair, distinguished participants, and dear colleagues. It is a really, really great honor to be here today and also a big responsibility. What we would like to do in the next 20 minutes or so is to provide you with a sense of the opportunities that we have, all of us collectively as an international community, in engaging with people who use synthetic psychoactive substances or with the disorders associated to this use. Let me take 2 seconds to share our presentation. Here it is. I'm waiting a couple of seconds to make sure that it will appear on your screen. And in the meantime, what I would like to say is that what we do hope to do is to set a scene in a way that on one hand responds to the urgency of the situation that is going on in many parts of the world, but at the same time firmly coalesce around the fact that there is a lot that we can already now do to support and protect the health and well-being of people who use and with use disorders, as well as support, if they so wish, their recovery, and therefore give not only a sense of urgency, but also a big sense of hope. At this point, I will take it for granted that all of us are familiar with the multidimensional element of synthetic substances that covers the use of very different psychoactive substances, some of them internationally controlled, some not, and with different patterns of use in different parts of the world. So I will not spend a lot of time in illustrating how the phenomenon includes such different dimensions as the use of fentanyls in North America that is driving a large number of overdose deaths, but also the expansion of the use of methamphetamines, or the emergence of synthetic cannabinoids, or the use of ketamine, to name but a few of the remarkable developments described by the last World Drug Report. I would like, though, to identify a couple of facts that need to be always kept in mind. First of all, this is by no means a phenomenon limited to men. In fact, women represent more than 40% of people who use some of these synthetic substances. In addition, the situation is much worse in prison settings. Let us not forget that prison does not stop drug use, including the use of synthetic substances. And in fact, people in prison settings have much higher rates of drug use, HIV, TB, and viral hepatitis. And again, even in this setting, the situation is worse for women. And finally, mortality. Mortality in general is still increasing, mostly due to hepatitis C and other liver disease, as well as to opioid overdoses, many of those linked to synthetic opioids. And this is certainly the urgency that I was mentioning in the title. As I see it, as an international community to respond to this situation, there are obviously a number of big challenges, but there are also opportunities for us to collectively build an effective response. And that is around these opportunities that I would like to organize the rest of the presentation. So, for example, the first opportunity that we have is linked to the fact that, largely speaking, as an international community, we do know which are the effective responses that need to be implemented. What you see on the slides are some key publications that UNODC has published with WHO, summarizing the scientific evidence with regard to all the services that are needed to protect and promote the health and well-being of people who use drugs and people with drug use disorders, and if they so wish, support their recovery. And on the slide, there is, of course, a particular focus on opioid agonist treatment, as well as take-home naloxone, because of the issue on opioid synthetics that I was telling you before. But let me underline here that when I mean all services, I mean all of them. I'm not thinking only, for example, at abstinence-oriented treatment, not at all, but all of the spectrum of services, from harm reduction to therapy, whether pharmacological, psychosocial, inpatient, outpatient, recovery support, all of those that are needed to support people who use drugs and people with drug use disorder. And we know that evidence-based treatment is effective. We know that it decreases drug use and HIV/AIDS. It decreases overdoses, it decreases crime, it decreases incarceration, prison overcrowding, and associated problems, and it costs less. It costs less than prison, it costs less than probation, and it costs less than doing nothing. At the same time, we also know that naloxone has been proven to be effective and safe in managing opioid overdoses, while not leading to an increase in use. And best of all, we have demonstrated this recently through our Stop Overdose Safely initiative, that this is effective also in low-middle income countries. So maybe by this time you're wondering, if we have these wonderful tools, Giovanna, what is the problem then? Why are so many people still dying? Why are so many people still suffering with drug use disorder? Well, let me show you. This is the problem. It is the treatment gap. Only 1 person with drug use disorder in 5 is in treatment. And again, this is particularly the case for women who are underrepresented in treatment. And we are recording this for the second regional group. Already in the first regional group, there were colleagues that were pointing out that these are averages, and therefore they can look very optimistic. So in reality, in many regions, in many countries, less people than that are in treatment. And how? How can we expect the health and well-being of people who use drugs and with drug use disorder to improve if the vast majority of them are not in contact with services? And this is our first opportunity, investing in the lives of people by providing all the services that are needed to promote their health, well-being, and recovery. This was the first opportunities. There are many more, and I would like to leave the floor to my colleague, Anja Bussel, to continue.
Thank you so much, Giovanna and everybody. And we just would like to continue also unpacking the situation with you, what can be done kind of in terms of engagement and treatment for people using different types of synthetic substances for non-medical purposes, of course. And fentanyl was mentioned before, is driving very much the overdose crisis. It's a synthetic opioid, much, much stronger than heroin. And that brings about a few challenges or considerations, but that can be addressed by adjusted programming, right? So on one side, as said, a much more potent substance. So that also comes along with higher rates of tolerance and physical dependence, which are associated with non-medical fentanyl use, which can be, though, reacted to or which can be treated through an adjustment of treatment protocols, especially opioid agonist treatment with methadone or buprenorphine, which will then also need higher dosages, with nevertheless this population will be responsive to. And then, I mean, overdose response, you've also heard before about naloxone, which is an emergency medication in cases of opioid overdoses. And also here, kind of due to the pharmacology of fentanyl, it might require, if somebody has an overdose from fentanyl, multiple administrations of naloxone till somebody can come back or be reverted from a fentanyl overdose. Fentanyl in general is shorter acting than heroin, especially injectable fentanyl. And therefore, the people that are using it for non-medical purposes are using it more frequently throughout the day to avoid withdrawal, which brings along kind of a risk on one side of a higher exposure to the possibility of bloodborne infections such as HIV or hepatitis, and each and every time, of course, also the risk of overdose. So with that in mind, the opportunities, or what we already know, bringing together with what we have to kind of develop, would be on one side, do more of the same, what we're already good at, increase the coverage of evidence-based services for people with opioid use disorders, including fentanyls here, which means also easy accessibility of methadone, buprenorphine services, more accessibility, more programs on take-home naloxone, and all of that accompanied by psychosocial support, as many people with fentanyl dependence are also very marginalized, often homeless, and so on. And then kind of what needs to happen or what needs to change is that we really need to tailor treatment services and systems better to the people with fentanyl dependence. We have already talked about the need to revise and review clinical protocols to adjust for the higher dosages that they need. There might also be different formulations in which medications are given, or different types of medication in addition to methadone or buprenorphine that are currently being used clinically and are under research regarding future evidence. And then there are other ways how to reach people that are using fentanyls and how to save their lives. One could be through medically supervised consumption rooms. It's also very important to involve people with lived experience in the co-design of services so they meet their needs and that they're attractive enough for them to use those services. And yeah, take-home naloxone and addressing marginalization with that. But all of this needs, in principle, monitoring and evaluation of the clinical services, the good practices that are emerging from there, and more research. The World Health Organization, our colleagues, are very soon to launch updated guidelines on psychosocially assisted pharmacological treatment of opioid dependence. And pretty sure this will be looking also more into what needs to be done for fentanyl use disorders. Another thing that we're expecting for the new guidelines of WHO to be reflected more is the new development around depo-buprenorphine. Buprenorphine is an evidence-based medication for treatment of opioid use disorders. The new depot formulations make it easier for some patients because they don't require daily dosing, but people will be covered with one injection of buprenorphine for up to 4 weeks, which for many will make their lives easier. It might not be the preferred option for everybody, but it's an additional medication formulation that we have. And from anecdotal evidence, it seems that it also works pretty well with marginalized or unstable populations using, for example, fentanyls. Then moving from the synthetic opioids over to the synthetic stimulant, there are also a few important opportunities and considerations. On one side, we have kind of summarized available evidence on what works, including in these 3 publications: the International Standards for the Treatment of Drug Use Disorders, a discussion paper on stimulant use disorder treatment, and guidance around HIV prevention and care for people using stimulants and the harm reduction responses there. In this kind of discussion paper, the psychosocial interventions recommended are especially contingency management, also cognitive behavioral therapies and family therapies that can be trained and in principle implemented at community level. In the paper, we are also discussing kind of what's the prospects for pharmacological treatment of stimulant disorders. And I think the message here is that, we will need different medications for different kind of types within the treatment stages. One would be to treat an intoxication with stimulants, another to treat withdrawal or relapse. And there might be not one medication that works for all types of stimulants. So overall, we will need more research. But research is also underway. Here you see on one side the Cochrane reviews, which are really the gold standard when it comes to medical advice. And as often also usual, right, in Cochrane reviews, they say, well, first and foremost, we need more research, and there's not the one gold standard maybe emerging. I would say contingency management at this moment comes very close to a gold standard. But again, more research is needed here also to see what works in communities. And as mentioned before, research is also ongoing in terms of medications that can be used and that would help us quite a bit bring stimulant treatment also to scale. So for example, there has been a promising study on bupropion and naltrexone. There's currently a mirtazapine study ongoing, and there have been quite a number of studies with long-acting amphetamines like lisdexamfetamine. None of this is evidence-based at this moment, but we hope that future research also with different subgroups will bring about a medication that can also work for stimulant use disorders.
Thank you, Anya. And let me take over to think about another kind of substances, of synthetic substances on which we get a lot of questions very often. And it's more than the substance, is about the setting and thinking about the emergency settings when doctors need to deal with a suspected overdose and they don't know what the person has taken. And with the huge increase in new psychoactive substances that keep on coming in and out of markets at a very high rate, this is happening more and more. And what we would like to point out is that here there is another opportunity to strengthen our responses and really think about the fact that, yes, we might never be really able to catch up with the number of substances coming in and out of markets, but there is a lot that can be done to save lives using some symptomatic care. So responding to symptom. And there are very good guidelines that have been developed in the United Kingdom and that have been picked up by us in UNODC. We have been training around the world on this. That can be very, very useful in this first step. The next opportunity is moving on a little bit. So far we have thought about different kind of substances, maybe a different setting. Here I'm thinking about populations that are underserved. And I was already mentioning in my introductory remarks how often the situation is worse in different ways for women who use drugs and women with drug use disorder, including when they're pregnant. And let me say at the outset that also here, as an international community, we don't have many excuses. Women do respond as well as men to services that are tailored to their needs. And we have a lot of guidance on how to create services that respond to the need of women, girls, and including pregnant women. And you can see them on the slide. And on this slide, I had tried to summarize what would be a service that is comprehensively focused on women and of high quality. I don't have the time to go through the slide now, but you can see here a lot of work around trauma-informed care, safety, childcare responsibility, and responding to health issue and socioeconomic issues that might be particular to women who use drugs and women with drug use disorder. So there is a lot that we can do to strengthen those responses. And I think that the same can be done for adolescents with drug use disorder. In the standards, and here on the slide, you can see some guidance from SAMHSA, that is from the Substance Abuse and Mental Health Administration in the United States, that is focusing and really highlighting behavioral approaches and family therapy as good responses for this group. This has been confirmed, for example, in a recent review of the evidence. And here you can see how the evidence not only mentions well-established interventions like family therapy, cognitive behavioral therapy, and multi-component therapy, but also looks at adjunct interventions like pharmacotherapy and digital strategies. So there is a lot that we can build on already to respond to the needs of younger people. And with this, I would like to again pass the floor to Anya to tell us more about another very underserved population.
And as we are coming to talk about people in contact with the criminal justice system and in prison, maybe just to note, as we are looking at the first slide, that there are a number of synthetic substances that in different regions in the world seem to appear a lot, kind of especially in prison settings. It's not always the same, but cannabinoids have been mentioned, pregabalin has been mentioned, and others, right? Because they have maybe also the feature that they can be smuggled relatively easy into prison settings. So synthetic drug use is definitely a challenge for people in prisons and in contact with criminal justice system. So we first and foremost have kind of guidance both to facilitate alternatives to conviction or punishment for people who use drugs with drug use disorders in contact with the criminal justice system, and then also a number of technical tools that guide us in terms of what's effective in the provision of treatment within prison settings. So the technical tools are there, but there's also strong policy support at the level of the General Assembly. And to mention here, the Tokyo rules or the minimum rules for non-custodial measures, the Bangkok rules, which are those kind of adjusted for the needs of women, and then the Mandela rules, which are the rules for the treatment of prisoners. A lot of people who use drugs are in contact with the criminal justice system at some point in their lives, and many people in the criminal justice system have a history of drug use disorders. And if you look at this red slide kind of here, or the red graphic here, you see that these are UNODC estimates at the arrest stage and at the conviction stage. More than 50% of people in contact with the criminal justice system for drug-related offenses are so for drug possession for personal use use only. And that is an offense which, in line with the International Drug Control Conventions, people can be diverted to alternatives to conviction or punishment. And we know on the other side, and Giovanna had mentioned that in the beginning, that incarceration will surely not reduce drug use, that on the contrary, there are higher prevalence rates of drug use in prison than in the community, nor will it have an outcome on recidivism for people with drug dependence or drug use disorders. And we have mapped out in one of the technical publications mentioned before how alternatives to conviction or punishment can be offered from the legal system perspective along the entire criminal justice continuum, from pre-arrest through to post-sentencing. And what is really good news is that there are a lot of interest in doing so from the UN member states. We have done a mapping where this graphic is from. Many countries have at least one alternative in place. Some countries have a number of alternatives already in place. And even the countries that do not have and that responded to us said that they would be really interested in developing such. And this is where our technical assistance projects to countries are going to. So I think with this, we also wanted to say a few words kind of around stigma, human rights, doing no harm, and all of that. And in this context of synthetic drug use on one side, let's keep in mind that compulsory treatment is not effective, right? So, and it's not in line with human rights. But what we can do is really develop therapeutic relationships and engage people using drugs and with drug use disorders, and use the evidence-based tools that we have available. So we're offering effective healthcare and not punishment. And we have also tools available that help us to embrace and monitor the quality of substance use disorder treatment services. Those are developed by UNODC and our partner organizations. You see here some of the standards or the criteria. And what's really important, one of the criteria is the involvement of peers in all of this quality appraisal and assessment. The workforce is equally important. So all of us, we would need to invest in a well-trained and an empathetic workforce so that we end not only stigma, but also neglect and ignorance at the same time. We know a little bit what works in addressing stigma, and these are often meaningful interactions. One of the things which we could offer in the framework of the Stop Overdose Safely initiative that Giovanna mentioned before, where we train people likely to witness an overdose, including kind of family members, people using drugs, first responders together. And here you have the quote from a person using drugs who participated in the training and who said, "I used to think that everybody was just waiting for us all to die. And now I see that people actually care how to save my life." So I think that was a strong kind of anti-stigma message there. The other thing, which is really around not doing harm, is to apply principles of trauma-informed care in all services where people with drug use disorders are, due to the high rates kind of traumatic experiences they have had in their lives. And that's something that can be easily learned by everybody. So with that, I hand over back to Giovanna.
Sure, and I only have a few words of conclusion from us to all of you. And I hope that we have given you a sense of how investing and building in a strong system of services for people who use drugs and people with drug use disorder can go a really long way to address the urgency of the mortality and the urgency of people suffering with drug use disorder and related health and social consequences, and really move, in a sense, from firefighting to a real long-term gain in promoting the health, well-being, and recovery of people who use drugs and people with drug use disorder, including, of course, and this is the focus of our talk today, people who use synthetic substances, and really move, therefore, from urgency to hope. So that's how we come back to the title of our presentation. And with this, just give us a second to be on camera again. And again, thank you for your attention and your participation from the United Nations Office on Drugs and Crime here in Vienna. Thank you.